Ladies and gentlemen, good morning. We welcome all of you to the morning session of our symposium Evidence-Based Healthcare, which is taking place in Krakow at a beautiful venue at Kościuszko Mound. We would like to welcome everyone who is gathered here in the room with us, who have yet to join us in the room and are now arriving en masse to our session. We're also welcoming everyone who is joining us online. Hello and welcome. Let's start with our first session, which will focus on innovation in HTA. HTA is by no means a static field. We continue to develop, we continue to acquire new information, and we introduce that to our reports. We keep going forward. And to quote one of the Polish politicians, I'm always learning something new. That's what we try to do. We have some interesting guests in this session. We have 3 guests from Australia joining us online. And I have Mark sitting right next to me who will give us an interesting lecture. Let us open with Justin Clark. Clark is the head of research at the Evidence-Based Healthcare Institute. His institute searches for information, and he will give us a lecture on efficient HTA literature searching. This is a vital element of HTA. Whenever we are drafting annual reports or clinical analyses or economic analyses, we devote a lot of time to search for information. That is because we need to find the right information for synthesis and then analysis as the next step. We need to find out the right information to identify safe and secure medical technologies. This takes a lot of time. That's why efficiency is of the essence.
Hello to everyone. I'm Justin. I'm just going to start by hoping that everyone can hear me okay. I'm going to assume the fact that no one has cut in to tell me that they can't hear anything, or that no chat has popped up, to assume you guys can all hear me okay. I'm just going to give a brief discussion. I think I have about 20 minutes to talk about innovations in HTAs. So what I'm going to do first is I'm going to set the scene a little bit, talk maybe a tiny bit about HTAs in Australia, the little bit I know. Then I'll talk a little bit about one of our case studies, so something that we have done, and then talk about some of the innovation and innovative new automation tools that we use in order to conduct our reviews much quicker. So thank you for that wonderful introduction, and thank you for the invite to speak. It is quite a privilege to be here, and my apologies that I could not be here in person. I would love to come, and I'm planning on being at least near Poland next year for the big Prague meeting, but I recently just returned from London, the Cochrane meeting, but unfortunately couldn't extend my stay to then be able to come to this in person. But thank you for the invite to present online. So a little bit of background about myself. I'm Justin. I am a health librarian by background, so I was a health librarian for a very long time. I've now moved to the Institute for Evidence-Based Healthcare, where I take up a research position and where I run and lead the automation program, so where we build all of our tools. And I also search for a lot of systematic reviews. I'm also a Cochrane information specialist. I have just come off after 6 years of being on the Cochrane information specialist executive. And I also teach searching to a lot of health librarians across Australia. So that's a little bit about me. So today I'm going to talk about the need for innovation and efficient HTA literature searching. I'm also going to talk about some of the tools that we use as well that fall outside the scope of searching, just to try to give a full, I guess, overview of the entire workflow that we use and where we use those tools. So I guess I'll just start. This will only be very brief. So we do HTAs in Australia, of course. So we do them for much the same reason everyone else does them, to test pharmaceuticals, diagnostic tests, and any other interventions, just to ensure that the government funds, that anything that the government funds, of course, is worth funding. That is, of course, the whole point, that any interventions funded using government or taxpayers' money actually have good evidence behind them and safe and effective for use. And my apologies, this slide's a tiny bit busy, but basically we have one overview body, so one called Therapeutic Goods Administration, which assesses kind of everything. Under that, we have three other bodies: Medical Services Advisory Committee, or MSAC, Pharmaceutical Benefits Advisory Committee, or PBAC, and Prosthesis List Advisory Committee, PLAC. I have done a little bit of work and training with the MSAC group, and one of my good close friends and colleagues, she came from the MSAC group as well. So that is kind of where I know most about HTAs in Australia. Tiny little bit of background about where I work and my institute. So I work at the Institute for Evidence-Based Healthcare, based at Bond University. That's on the Gold Coast. We're today, and it's currently 5:06 p.m. Australia time. So we focus primarily on four big areas in healthcare. We focus on antibiotic resistance, overdiagnosis, non-drug pharmaceutical treatments, and waste in medical research. And we also now invest a little bit in automation to try to make researching all of these things a bit easier. But that's our primary area of interest. As part of that, we do a lot of systematic reviews to kind of look at all of these different areas. And I'm going to be talking more from a systematic review perspective, as our institute doesn't do HTAs, although a lot of us have done HTAs in the past. We're not a HTA body at the moment, but we do systematic reviews a lot. It's one of our primary research publication types. So we publish 20 to 30 reviews a year, generally. So we do a lot of reviews, and so we know a lot about reviewing evidence and synthesizing evidence. And I know HTAs involve quite a bit more work and a bit more involved in a systematic review, but there is a lot of overlap. So hopefully all of the things I'll talk about today from a kind of more systematic review perspective still hold a lot of relevance to the audience who do HTAs. So we're primarily grant funded, or we used to be primarily grant funded. Recently now, though, we have moved to do commissioned evidence reviews. This is for the government, for the Australian government, where maybe they don't quite want a HTA, but more a position paper or evidence on a new intervention they might be trying to fund. So we do commissioned evidence reviews for them, where the topic aligns with our areas of interest, of course. But so that's kind of the perspective I'll be talking about today, and I'll be talking about one of our commission reviews in general, and the workload involved in that, and kind of how we apply innovation and automation tools to be able to deliver evidence to the government in a timely manner. So I'm just going to set the scene very quickly about this case study that we did for the government, or well, I shouldn't say this is a case study of a large body of work we did for the government. Sorry, I should say. So during the COVID epidemic, of course, it wasn't safe to really go out to the hospitals or go to see your GP. So the government wanted to see and invest more heavily and to expand its telehealth services that it funded and provided. But they didn't want to do so if it wasn't safe, of course, and if outcomes for the patients were not good. So they commissioned us to review the evidence on the efficacy of telehealth, generally in primary care, so in general practice or in family medicine, allied health services. So the types of services that you might get in the community outside of the hospital environment. So, of course, the first thing you do need to do is you need to determine where there is strong evidence about the telehealth and the delivery of primary care. So this is what we do first. This is because we don't want to have to do reviews. We don't have to review evidence when there's already very good and solid evidence. So we can make, where there's really good evidence, we can make recommendations to the government without needing to do a large amount of work, where the evidence maybe is a bit lacking, or where there's not good review evidence or really large trial evidence. Then we need to do reviews to find that evidence. So we start off, we design a search that finds all reviews and RCTs on the topic in telehealth and primary care. We then went through, we screened and we grouped together all of those reviews and all of those RCTs to create a bit of an evidence map. Then we could look at where there was evidence and where there wasn't evidence, and then we could summarize the existing high quality reviews and then do new reviews in areas where there were evidence gaps. Of course, when you're summarizing evidence, you need to ensure that it's very high quality and it's all up to date. So we need to assess the quality of that evidence. So this probably, hopefully, is not too new to anyone, but we use fairly common standard assessment tools. So we use the MSTAR checklist and Cochrane risk of bias tools on our reviews and our to determine if the evidence was of high quality. Where it was, of course, we just summarized that evidence. Where it wasn't, we did a new review to be able to get good evidence for the government. Of course, and check the search dates, of course, of the review, because if the review is 5 years old, it's out of date and we need to update it. That's one point where we use automation tools for that. And I do talk quite a bit about the automation tools in the last 10 minutes, in about a minute and 40 seconds. So basically, if a high quality review exists, we summarize that review. If a high quality review did not exist, we conducted a new systematic review from scratch. So then we had to go off and we had to find the evidence. So we found evidence for 21 different topics, 9 of which did not have enough high quality, good, up-to-date evidence existing for us to be able to utilize that evidence. So we had to do 9 brand new systematic reviews from scratch. And of course, this was very time sensitive. The government needed this information quite quick. So we had to compile our entire report in 3 months. So this is 9 reviews in 3 months. It's of course quite a fast time frame. So we utilised automation tools that we've developed, but we also used our I think reasonably well known now 2-week systematic review method. This is a method that enables us to integrate a few different bits and pieces. Automation tools is one of them, in order to do a full review in anywhere from 1 to 2 weeks. And without kind of those methods and that innovation and those new techniques and new tools, there's no way we could have provided the government with the evidence it needed in such a short time frame. This is looking a bit blurry on my screen. I'll see if I can't expand it. No. But these are the topics, and my apologies if it's a bit blurry. Basically, there were 21 topics we needed to do. These are the 9 full systematic reviews we did, and I've just got some of my excellent collaborators in there, all of whom had to work very hard in order to provide this evidence. So this was the final 9 reviews that we managed to get finished and completed in a 3-month time frame, as well as summarising the evidence from the other 21 minus 9 topics. I think that's 12 topics. So to do that, we had to use our 2-week systematic review method. Those of you who are interested in kind of learning a bit more about 2-week reviews and how we do them, and some of the details and background to them, we have published 2 papers now. We published a paper back in 2019 on 2-week reviews, our first case study, so the first one we did. We've then extended that whole method to incorporate larger, more complex reviews, and we've also provided some pretty good guidance in our most recent paper, which I think was this year, on how to do kind of more complicated systematic reviews in these quite accelerated timeframes. So conducting these sorts of reviews is very difficult. So We use automation tools a lot, and they're all part of our workflow. But before I talk about automation tools, it's also important to acknowledge the fact that we also have a lot of skilled people and very skilled teams with a lot of review experience. So it's not just a matter of incorporating automation tools into your workflows and getting massive time savings, although you can get substantial time savings quite quickly. You also do need that experience as well in order to kind of get reviews done that quickly. But from experience, anyone can kind of integrate automation tools into their workflows and get quite large time savings quite fast. So this is our website. So this is the site we use. These are the tools we use. It's called the Systematic Review Accelerator. All the tools are free. Anyone can log on and use them straight away, today even. If you get a bit bored during my talk, you can even log on and start using it now. So I think the website's there, sr-accelerator.com. All the tools are there. We run training if you want to get on and learn to use them. These are the tools I'll now be talking about and kind of where they fit into the workflows and how they can really speed up review production. I'll skip this because I'll talk about all of them, but this is just an overview slide of all the tools that we use and which task we use them for. So the first tool we use, and this is probably, it's not a searching tool, and I know my title was searching, but this tool is kind of so good that I always like to talk about it. So this is our methods wizard tool. So this is a tool that will write the method section for you, and it will create a method section for you, but it also helps you design your review and focus your review questions really quickly. There's just a whole bunch of pre-built, there's a bunch of empty fields you fill out. It's all structured, so you flow through, you put in your PICO criteria, you put in your search terms, you talk about the data you want to extract. So you kind of just fill in all the empty boxes. Then you hit a button, and that then generates and it writes your full method section for you, pretty much ready to go. It's about 95% right. We normally spend maybe an hour tops just tweaking it and re-editing it a little bit. But we can have a full review method section written, ready to go in about 2 hours, which is a substantial time saving. The other great thing is that it's shareable, so you can just share this link, maybe with funders or co-authors, and they can actually have a look and see exactly what you're doing. They can then edit and make any changes that they want to make. So we found this very helpful as well with collaborating with people. Our second tool, so this is a search tool. So this is a text mining tool. So when you're building searches, and I'm just going to talk a little bit about searching in general now for 30 seconds or so, but when you're building searches to find evidence, it's really handy and really useful if you can pre-identify a couple of studies that are relevant to your topic. You can then use these studies to help build really innovative and really highly focused searches. And a focused search means it finds all of the evidence while also minimizing the amount of irrelevant evidence that is found. So, you find all your relevant evidence, but the amount you then have to manually screen is drastically reduced. So we use the word frequency analyzer as a tool to help with that. So we upload some pre-identified, so already identified, normally by the content expert, studies. It just goes through and it just counts out which words appear lots of times, with this basic general idea of building a good search means you should use the words that appear lots of times in relevant studies as part of your search. And that's how we get started with our search strategy. And I still use this. I've been building searches for reviews for 20 years. I still use this tool now to get started, and I can have a fairly good search going in half an hour just by using this tool. So text mining, I think, is a really innovative, a really nice way to get a really good draft search going really quickly. The next tool is the Search Refiner tool we use. This is a collaboration with the University of Queensland here in Queensland. So when you've built a search, normally, you build a search to make sure it finds all of the evidence. And then once you're happy with your search and you think it's found all of the evidence, then there's a second step, which is what you use this tool for. This tool is then what you use to refine your search, so it reduces the amount of irrelevant evidence that it finds. And we find that we can reduce the amount. So if you reduce the amount of irrelevant evidence you find, you have to screen far fewer studies, means you can get to data extraction and completion of your review much quicker. We find we can get a drastic reduction. So we can reduce screening load by about 50% just by using this tool. If we spend 1 or 2 hours using this tool to help refine a search, we can drastically reduce screening load by up to 50%, sometimes even more. It's quite easy, quite neat tool, and it's got a lovely search interface and a nice graphical interface. And that was, sorry, and on the screen is a search, which is a before refinement. So you can see it's big, lots and lots of words, lots of spokes, very complicated. And then the one afterwards is the refine search. So it's far smaller, far fewer words, but it's the right words that you need to use in your search. So it's still finding all of the evidence you need. But I think in this case, the screening load is reduced by about 80%. So it's 80% reduction in screening workload. So then the last tool that we have for searching is our polyglot search translator. This is the first tool we built. I think we built this back in 2018, I think. So this is a tool that will take a PubMed or an Ovid search and it will translate it into the right format and syntax for all of the other databases. This is very handy. I mean, even for a search expert who knows what they're doing, it can be quite a long process to take a search and change it and modify it for all the other databases, because when you search multiple databases, when you do a review, you have to search multiple locations and multiple databases, and it can be time-consuming to translate it manually. This does it for you automatically, and unfortunately, I can't show it live, but basically you paste a PubMed search in, and then you just copy a Cochrane search out, for instance, paste that into the Cochrane database, and your search is done. So full translation of all your searches, I can have that done in 5 minutes now, and it's ready to go, compared to maybe 2 or 3 hours it used to take me in the past. In exciting news for HTA, we've partnered now with IQWiG, so the big HTA agency in Germany, and we're going to now add in a couple of HTA databases. I think Inata database is going in soon, so it'll soon be more usable for HTAs, which is quite exciting. So I'm now down to 1 minute left. So I'm going to power through the last couple of tools that we have. We have a deduplicated tool, very easy to use. You just have to upload your search results into the deduplicator, and it will process and help remove all your duplicates for you. We have a couple of screening tools. So these are like Covidence or Rayan, except ours have a little bit of user interface, I think, improvements. So we have Screenatron and Disputatron to help resolve screening and screening disputes. We then have a very neat tool called SpiderCite. So this will automatically do a forwards and backwards citation search for you, which is also, again, a process used to take me manually doing in Scopus Web of Science. Might take me an hour or 2 or 3 hours. This is now done for me in 30 seconds. So massive time saving on citation searching. And then finally, RevMan Replicant. So we use RevMan 5 or Review Manager 5 to do our meta-analysis. If you upload your RevMan 5 file into the RevMan Replicant, it will write your results section for you automatically. And that's it. That's all the tools and all we do. And hopefully that was just enough to get you interested in looking at the Systematic Review Accelerator and starting to maybe use some automation tools to help out.
Thank you, Justin. Very interesting presentation. We have a set of questions and discussion after all presentation. Right now we move to the next presentation. Our speaker will be Magdalena Ruth-Moshi. Magdalena is także z Australii.
Magdalena is also from Australia. She is a senior research officer at the Royal Australasian College of Surgeons. Sorry, it's a difficult name to pronounce in Polish and in English. She conducts health technology assessments as part of the Australian Safety and Efficacy Register of New Interventional Procedures Surgical. So this also falls within the scope of our interests, and it certainly is a challenge.
To też jak gdyby ciekawe dla nas doświadczenia.
The experience she will share is very interesting.
Thank you for the kind introduction. Today I'll be presenting a HTA framework for digital technologies from an Australian healthcare perspective. So what is a digital health technology? Digital health technology is the electronic transfer of healthcare, and healthcare resources. For the purpose of this presentation, e-health and digital health technology will have the same definition. Within this presentation, I'll be providing a brief and simplified overview of telehealth and how medical software is regulated in Australia. And I'll also be detailing a module I developed to assess a subset of digital health technologies known as applications. This diagram briefly shows up where mobile medical applications fit within the wider digital health technology. So this part of the presentation will focus on telehealth services in Australia. Before I provide an overview of telehealth in Australia, I'll provide a simplified summary of Medicare, Australia's universal health insurance. The system enables access to health and inpatient, outpatient hospital services at minimal to no cost. Medicare is available to all Australians, Australian permanent visa holders, New Zealanders, and countries that have reciprocal agreements. All Medicare services listed on the Medical Benefit Schedule, or the MBS, are reimbursed through Medicare. In order for a medical service to be listed on the MBS, it first must undergo a HTA that is overseen by the Medical Services Advisory Committee, or MSAC. If an item involves a medical device, said medical device has to be regulated by the Therapeutic Goods Administration, or the TGA. There are approximately 253 active telehealth items. This is either telephone or video conference items on the Medicare benefit schedule. The telehealth items are not limited to medical doctors. There are also items for Aboriginal and Torres Strait Islander health workers, allied health workers, social workers, nurses, and midwives. Between 2021 and 2022, approximately 53 items related to telehealth were removed from the MBS. The items that are removed could be claimed by all the health practitioners previously mentioned. Overall, of the 306 items on the MBS, active ones or inactive ones, only 16 were introduced prior to the COVID-19 pandemic. The first items were what was introduced in 2006 and was only available to medical doctors. In 2011, items were added for midwives, and a further 6 items were added in 2017 for allied health workers and social workers. Items for nurse practitioner were added prior to the pandemic. However, the exact year they were introduced is unclear. During the 2019 COVID pandemic, around 290 telehealth consultation items were added to the MBS. In 2021 and 22, 15 of these items that were added before the pandemic were removed from the MBS. These items were permanently replaced by newer items that were introduced during the COVID-19 pandemic. The only pre-COVID-19 MBS items that was not replaced was the one introduced in 2006 for medical doctors. This part of the presentation will focus on providing a very brief and simplified overview of medical software regulation in Australia. Medical software can include computer programs, mobile applications, website, software as a service, and cloud-based items. In Australia, medical software can either be regulated as a standalone device or as part of a medical device. Software that can control medical devices using wireless technology such as Bluetooth or Wi-Fi is regulated as either a standalone software or as part of a medical device. The type of regulation that is applied is dependent on context. Medical software is regulated as a software as a medical device, or an SAMD, in Australia if it can diagnose, treat, monitor, investigate a medical condition, as well as control contraception or compensate for injury or disability. Medical software is regulated as a standalone device if it meets the definition of a medical device, so the one I previously mentioned. Software in a medical device, or an SAIMD, is a software that is an integral part of a medical device. Software that is an integral part of a medical device is supplied alongside the medical device, is regulated as part of the medical device. An example of this is firmware or embedded software in a cardiac pacemaker. From an international perspective, the International Medical Device Regulators Forum, or the IMDRF, created a working group aimed at harmonizing the regulation of standalone software as a medical device. Australia's TGA is a member of this forum. In 2017, the forum published a guidance document titled Software as a Medical Device SAMD Clinical Evaluation. The document provides the level and type of clinical evidence needed to appraise standalone software for regulatory purposes. A brief overview of the reimbursement of software as a medical device in Australia. In short, at this stage, there appears to be none. None of the telehealth items appear to include any clauses for software as a medical device in any form. This part of the presentation will focus on a HTA module developed to assess a subset of digital health technologies called mobile medical applications. So simply put, a mobile medical application, or an MMA, is a mobile health app, mHealth app, that has an intended purpose that is diagnostic or therapeutic. From these two apps, the one is a diet app and the other is a melanoma detection app. This app is not a medical device because its intended purpose is not investigative, diagnostic, or therapeutic, whereas the skin cancer app is because it's detecting a medical condition. Unlike traditional software, MMAs pose different harms and risks. The major harm they pose is misinformation and how this affects clinical management. They have a rapid life cycle. They're available on various types of operating systems, Android or iOS, or platforms, smartphones, smartwatches, or tablets. They have robust real-time software updates. They are available on non-specialized software. And they have robust connective and capability abilities. And they provide real-time post-market data. So therefore, the evaluation of MMAs requires consideration from different dimensions than those typically available in medical service evaluations. So how do we properly regulate MMAs? In 2020, I published an evaluation module that is designed to adapt any current HTA framework that's either investigative or therapeutic to support the evaluation of an MMA. The module is based on modifying the traditional HTA domains that support the evaluation of an MMA. An additional domain was created to address specific challenges such as post-market modifications or updates. Some items that were traditionally considered regulatory have also been integrated into the HTA module to ensure specific technology items were evaluated. So this is an overview of the first part of the module. Regarding the first domain of description and technical characteristics, items that identify the MMA's operating system and platform need to be included. With regards to the use of the technology and the intended purpose of the MMA, as well as the MMA input, algorithm, and output need to be included. With regards to efficacy and effectiveness, specific items related to the analytical validity, which is an MMA's ability to produce the intentional output from correct input, accuracy, which is the MMA's ability to be affected by software errors, the configuration, which is the MMA's ability to withstand being configured in an unintentional way. Precision, which means under unchanged circumstances, the degree to which the concurrent measure input into the MMA generates the same output, i.e. reproducibility or consistency, potential software changes such as updates and cybersecurity, and the MMA's ability to clearly communicate and display health information would need to be included into the HTA framework. With regards to safety, the impact of misinformation on how the output of the MMA will inform clinical decision-making and patient management must be considered. With regards to cost effectiveness, specific considerations may include looking at attachable hardware, but a lot of the considerations would be specific to the HTA and dependent on the model that is under consideration. Finally, for organizational considerations, the impact of training and the education of users would need to be considered, as well as how the app interacts with current hospital informatics systems, how it would impact the utilization of current medical services and treatment locations, and how accreditation may be needed to use or prescribe the app. So additional considerations include ethical considerations, such as the equity concerns, such as language and literacy, access concerns such as geographic location, internet availability, as well as ability to access smartphone, privacy considerations and concerns, as well as conflicts of interests related to third-party sponsorship and funding sources. Legal considerations would include data ownership, which party is responsible for the medical advice provided by the app, which party is responsible for monitoring and reviewing patient data, the impact of information on the medical practitioner's professional indemnity, as well as patients' health and life insurance, and the impact of professional registrations and licenses for using or recommending apps. So this is a newly created domain which aims to address how post-market data could enable or disable functions. So this section is to be used to review after the MMA has been reimbursed to determine if a full HTA evaluation needs to be redone based on post-market data. The post-market data could trigger a new HTA if there is indication that the effectiveness or harms posed are inferior or superior to the ones stated in the original HTA, if the users have complained or there's a lot of adverse events, if data could affect ethical, legal, or organizational concerns, and if data could be used to enable or disable new MMA functionalities. And finally, if the collection for way of data collection implemented is burdensome on the user. Finally, with regards to societal concerns, this is the only optional domain. An MMA specific considerations would include if the app immediately changes patient autonomy, as well as how the app could the relationships of caregivers or impact the user's relationships. So there are a variety of study designs that could be used to inform the module. Novel single-arm studies or short-term trials, such as clinical simulation trials, have the potential to provide a unique pool of technology-specific data that could be used. For example, it could provide clarification on the MMA's intended purpose, the input, processing, and output, the technology-specific data on MMA accuracy, configuration, precision, and software updates, provide immediate information on additional training/education, and interaction with current health informatics systems and how adoption could affect utilization and treatment locations, identify equity concerns, such as if blind people were able to use the app, provide clarification on data ownership, responsibility for medical advice or patient monitoring, as well as be used as part of preclinical trials to test the feasibility of the MMA. The assessment of safety and effectiveness would need to be informed by comparative data such as non-randomized studies and RCTs. The traditional study lengths would be needed for cost effectiveness, using specific perspectives and societal, such as societal as well as time horizons. Traditional follow-up time point data would be needed to assess traditional safety and effectiveness, short-term and long-term data points. So to summarize, the strengths of the module are that it includes provisions for the evaluation of an app's analytical validity, cybersecurity concerns, software updates, post-market performance data, compatibility issues, and professional liability concerns. However, their limitations are related to the module is only applicable to MMAs at the moment, a subset of digital health technologies, and more research needs to be conducted to determine if the module can be adapted to perform a HTA on other digital health technologies. So closing remarks. To summarize, telehealth services are reimbursed through the Australian Universal Health Insurance System called Medicare. Software as a medical device are not. However, the technology is regulated. Digital health technologies were relied on heavily during the pandemic as there was a substantial increase in eligible telehealth items. With regards to MMA evaluation module, it includes both regulatory and reimbursement items, and it can be used to adapt existing HTA evaluation frameworks to evaluate MMA is a subset of software as medical devices as well as digital health technologies. Different levels of evidence can be used, such as single-arm trials, RCT, non-randomized trials, can be used to inform separate technology-specific items in the HTA. However, comparative data is preferred for effectiveness and safety. I would like to thank the Australian Government Researcher Training Program Scholarship for funding this part of my research. Thank you for listening. If you have any questions or would like to collaborate, please reach out. And that QR code should take you to a paper I published on the module for evaluating mobile medical applications.
Thank you very much, Magdalena. Very nice and interesting presentation. Hot topic right now, digital technologies, also not only, I think, in Australia, but also in our countries in Europe. Right now, please remember about the questions. If anyone wants to ask questions, please write it on the chat online, and these questions will be sent to me, and I will ask during the discussion session. Right now we move to Mark's presentation. Mark came to us from right now from Serbia, but he's originally from UK. Mark is a director at ZEM Solutions and is very experienced in health economics and data analysis. Today he will present to us interesting presentation regarding using real-world data and real-world evidence in economic modeling.
Yes. Yep. Thank you very much, Robert. It's an absolute pleasure to be here with you today. So just very quickly, short overview on Zem Solutions. So we are primarily focused Central and Eastern Europe. We do a lot of projects for market access for various different countries within the region, generally focused on ex-Yugoslavia countries, but we do branch out internationally to, I'm originally from the UK, so we do a reasonable amount from the UK. Really what I want to talk to you today about is this, what we've experienced within that process in terms of the value of real-world data, the process of turning that into real-world evidence, what that means, and how that ties into what we do in terms of market access and producing materials for health technology assessment. I'll start here in terms of one of the, as Robert was just saying, in terms of the hot topic. So one of the things that's really emerging at the moment is this idea of real-world clinical trials, virtual clinical trials. So this real explosion in mobile applications that collect data and operate outside of the normal clinical trial process. So this is very much an emerging trend. The date that I tend to refer to this is the iPhone arrived only in 2007. So we are now about 10 or 15 years into these awful technological devices that we're all horribly addicted to providing, but being able to provide data in a healthcare setting. This is an emerging trend. One that's much more established is patient registries. So, and one of the ones we've worked through recently is called ResQ. So this is a Central European originally focused database for stroke. And I'll come slightly later in the presentation in how this actual registry proved useful for us and the data that this was collecting. The actual registry itself is used a lot within stroke care for quality monitoring. So it's, and this is really one of the things I'll say in terms of all this idea of real-world data and real-world evidence. It's not just about health technology assessment. The whole stakeholder engagement throughout the process is very, very important. And it really kind of drives value and improvements within the healthcare system from where we were historically. And really what I want to focus on today is this kind of idea that you can combine these patient registries with other evidence to provide information and knowledge and really assist in the materials that are needed for health technology assessment. So that's just kind of two brief overviews of real-world data. What I want to do next is really separate what is the difference between real-world data. We tend, as we think of it, to use them interchangeably, but there's a significant difference between real-world data and real-world evidence. And the first place to start with that is to ask the question, what is evidence? Now, we really first asked this question about 18 months ago under the assumption that it would be really easy to answer. It's not. We actually had, and so if anybody's kind of coming into that and thinking, oh, what does this mean? We actually asked one of our lawyers, what's the legal definition of evidence? And after running through all his ancient school notes, just had a very top brief overview. Now, within health technology assessment, we tend to think of it as this evidence pyramid. So we have all this data at the bottom of the pyramid. We translate that into information where we put some kind of context and join this data together to move this into things that we can say we know, that we can then apply on this wisdom, which from a health technology assessment perspective is health technology assessment, using evidence-based decision-making to try and make decisions that improve the healthcare system. That's a very abstract, definition of what this means. I'd like to make that slightly more practical. So if we take some real-world data, we have somebody telling us something is a number 4. This is kind of what we look at from this data. A lot of healthcare data is observational. There is very little material we collect that is actually a physical measurement. So things like biomarkers, for example, we have a very physical meaning. A lot of other data we collect is interpretive. It's a doctor's diagnosis. Now that diagnosis and that measurement itself has a lot more complexity into it. So we say, okay, one piece of data isn't enough. So we collect data from somebody else and they say 3. And it's like, okay, we now have, we're starting to get a better picture here, but they don't agree on what they're actually looking at. If we introduce real-world data, if we introduce this big data into this situation, we now have 25 million people saying 4 and 25 million people saying 3. Really, how did that help us? Well, what you're actually looking for in here, and when you're looking for the evidence and what this means, is to try and understand the picture, which can be very different from what you actually expected. And this understanding of this context, now, we've had some really good examples of this over the last day or so. So this can be equity issues. This can be, are they, different perspectives of patients? Is it equitable access to treatment? It can be measurement issues. So one of the things I think was really important mentioned yesterday is the concept of mental health and how well that's measured in our measurements for outcomes. So these are the issues with what we mean by what is evidence. Evidence is something that tells us, that helps us make an informed decision. Data itself doesn't do that. You need to move it into this kind of context. So this kind of brings us up to the summary of where I think we are now in health technology assessment and real-world data and real-world evidence. In terms of decision-making, there is still a massive reliance on phase 3 clinical trial data. In terms of where we're coming with virtual trials and post-follow-up, yes, they are starting to have an impact, but it's still predominantly focused on phase 3 clinical trial data. There's a couple of important problems with that. First of all, phase 3 clinical trials are incredibly expensive and time-consuming. So you have this push to try and bring good technologies to patients faster, but clinical trials take a long time and are expensive. The other part that's important for this is they're not part of medical device regulation. So you don't have phase 3 clinical trials generally for any medical devices. So that makes health technology assessment of medical devices much more complicated for decision makers. This summary of real-world data and not real-world evidence. I think one of the first important things is generally real-world data is important to remember. It's generally measuring healthcare, not health. So I think it's very important for as you construct the materials to focus on the health of patients, not necessarily just on what was collected. Mental health is a really good example of that. What real-world data can we really collect on mental health related issues? Is it just focused on the acute aspects? The other things with this is it's very limited in place and time. So the data that gets collected, it's not necessarily clear how it translates from one place to another. So if you have, for example, a very large United States real-world data study, how well does that actually translate to a Central European context? And how can that actually impact the decisions? And the real kind of takeaway from this is the decision makers really value evidence and analysis. It's not, they don't care how much data they've got. What they want is a strong evidence-based analysis that really helps them make informed decisions. So this kind of leads us on to a project we got published just at the beginning of this year. So this was looking at the burden of stroke in Croatia. And really kind of what the final number you're looking at from this burden of stroke is how much does stroke cost per patient? This is kind of this knowledge aspect of the analysis. but all of the evidence that comes into this, you have a lot of you're taking it from publications, you're taking it from material that's from systematic literature reviews. One of the things we found really important and really useful for this was the ResQ patient database. So within Croatia is a member of the ResQ database, and there were two really important data points for producing this outcome that were very specific to Croatia. The first is how efficient are the ambulance services? So when somebody actually has a stroke, how many of them actually make it into the stroke care services? Because that, for example, is something that can vary significantly, not just between countries, but within countries. So, for example, within Croatia, they have a lot of islands. It's very different if you have a stroke on an island than if you have a stroke in the center of Zagreb. And trying to understand that burden is the type of, these patient registries are the places that data to give you evidence of this can be really important. The second part that was really important for this was discharge. So Croatia, and I think is possibly unique globally, has a very nice rehabilitation program where post-stroke you get to go and spend 6 months on the seaside in recovery. That isn't something that a lot of other countries offer. Quite a few modern countries have very limited stroke rehabilitation programs. So in terms of understanding that cost and the burden of stroke and how this goes, how this relationship goes from real-world evidence, real-world data to real-world evidence to the kind of statements that you can make to help decision makers understand the burden of disease that take place. And all of this is done with health economic modeling. So the idea from health economic modeling is we take all these different evidence sources, collect them together to produce these final outcome numbers that are used within the decision-making process. That fits as part of a larger project we've been doing within Zem Solutions, which is national health modeling. So we have this national health model Serbia. This is what's known as a potential outcomes model. So I think this was spoken very briefly yesterday. It's a patient-level disease model. So we model outcomes at the disease level and how interventions impact on that disease at the patient level and over patient lifetimes. So we can then, with the concept of being able to try and validate that against the real-world data that we can collect. So this is over the last 12, 18 months, really kind of where we've been focused in terms of trying to provide evidence that the models that are actually being produced are representative of what's actually happening in the real world. And part of why we can now do this is the tools of the trade are changing. So for pretty much all of my career, basically, the kind of primary tools that get used for deliveries of these technologies, everybody's familiar with. Microsoft Excel, Microsoft Word, Microsoft PowerPoint that we're using today to transfer this knowledge from one person to another. And then the data tools that sit underneath this. So databases, software programs like SPSS and Stata to do the data analysis. What's really evolved with very, very recently is a software package called R. So this is a free software that is very, very powerful for statistical analysis that basically replaces a lot of those other kind of tools that we can get to pretty much everybody in terms of the analysis. This has also enabled us to move from this sort of online analysis package to being able to just give people our data that we predict, and the R tools to do the analysis that then we've been working with a local stroke hospital in the center of Belgrade to say, this is what we think your stroke patients should look like, this is what we think their properties, this is what we think their outcomes should look like based on the modeling, that they can then use with their ResQ patient database to say, well, these are the differences, these are good estimates, there's something wrong here, to try and understand what this relationship is between what the evidence says should be happening versus what actually happens in the real world. An example of where we take and use that is because we're looking at this of how interventions come together, we start being able to produce predictions of how medicines will be used as the healthcare and diseases change. And part of that is, we started calling this real world context. So one of the things, for example, your healthcare system changes when the decision makers make decisions and change reimbursement process. Well, what does this look like? So if you look, for example, in 2018, so Serbia has this idea of this positive list. So medicines to be provided and paid for by patients need to be on the positive list. In 2018, insulin degludec wasn't on that list. And as an entire nation, Serbia was spending about 11,000 euros, not just out-of-pocket payments of people wanting insulin degludec. In 2019, that was added to their list A. So what change does this make? You're now spending close to, I think it's 4 million, is that? Yeah, so 4 million increase in the use of that insulin degludec, a good diabetes medication that is now going to have knock-on effects for the next 10, 15, 20 years in terms of patient outcomes. But the decision makers, what they see instantly is we just started spending 4 million euros more on our budget. So what does that actually, how does that actually look like? This kind of when you're talking post-monitoring follow-up, do they start to see the changes in outcomes that they're expecting for that investment in health? So this is this idea of real-world context and where HTA fits into this kind of process from the modeling perspective in terms of what this looks like. The other side of this is what we can start to see in terms of these unexpected outcomes. So within stroke, we've done a lot in various diseases. So sort of all of these that are on here, there's cardiovascular, diabetes, a lot of oncology. Some of the first work we did was actually in rheumatology, and the new biologics there that are it's game-changing for rheumatology patients, horrific for national budgets. And this is really what we talk about from an HTA perspective. One of the examples I give is from when you come at it, HTA from a UK perspective, HTA is a way for the UK to say no to medications. From a UK perspective, doctors will generally prescribe something and they're trying to find a way to say, please don't do this, it's really expensive. But from a Central and Eastern European perspective, it's a way to try and get very tight budgets to say yes to get outcomes for patients. So what you see from this is looking at kind of what happened with statins and lowering LDL cholesterol, and what happens when you put that kind of treatment effect into outcomes. Now, there's two really big impacts on lowering cholesterol. First is it lowers your risk of myocardial infarction. The second is it definitely lowers your risk of stroke. And you see from this graph how much this, in terms of mortality, is expected to actually happen. But when you put them into this kind of lifetime outcome, you actually see the opposite effect for stroke than you would expect. So the higher LDL cholesterol levels in your population, even though you've reduced the risk of stroke, actually end up being higher in the low LDL cholesterols long term. And this has actually been reflected in the literature in terms of a lot of doubt placed on stroke. What is the reason for this? It's actually very simple. It's almost like this graph that I showed with the 3 and 4 logs. The reason for this is the myocardial infarction mortality is so high that high LDL, that when you lower the cholesterol, you end up with a lot more people alive in their 70s and 80s to actually have a stroke. So although individually their risk is lower, at the population level, you end up with more stroke events simply because there are more people alive, and this is more people alive in their 70s and 80s to actually have the stroke. And this is This is, I say, 20 minutes of me trying to get that whole process in. I hope it was entertaining. I think in terms of, just to very quickly finish, in terms of challenges and opportunities, really it's all about the validation. Really, real-world data, real-world evidence, it's as much about the validation of decision-making, of the types of things that have been collected in the literature, and to try and pull those things together. And I shall finish there and say thank you very much.
Thank you. Jak to cudowna dzisiaj
You're wonderfully keeping to the time. Everyone is sticking to the time discipline. I'm really impressed. Let's move on to the last presentation, and our last speaker, that will be Bonnie Parkinson, also from Australia. Bonnie is an associate professor and interim deputy director and a health economist at the Macquarie University Centre for the Health Economy. She has also worked with PBAC, so she has vast experience in HTA, and she will share her knowledge with us. Bonnie will be discussing a big problem in HTA, that is uncertainty. Bonnie, the floor is yours.
Well, thank you very much. I wish I was there to be there in person, but unfortunately I'm stuck here in Australia at the moment. So I'm going to be talking to you about uncertainty. So I thought I might first talk about what exactly is uncertainty. So firstly, we have variability, which is every patient reacts differently to an intervention in terms of efficacy or safety, just simply by random chance. And doctors will often encounter this in their practice. Then we have heterogeneity, where some differences between patients can be explained, and this might be through demographics, such as their age, or biomarkers, such as genes. And finally, we have uncertainty. And what we mean by this is what will be the true impact of an intervention on health and costs for all patients. How we get at uncertainty and working out what the true impact is generally through randomized controlled trials in the healthcare setting. And so they're considered to be the gold standard. However, they don't often collect all evidence regarding health and costs for a variety of different practical and ethical and financial reasons, such as the comparator might be placebo and not actually current practice. They're usually conducted in highly selected populations, ones that don't have a large number of comorbidities. There's often maximum compliance within the clinical trials. They're underpowered for economic outcomes and adverse events. They often use surrogate outcomes rather than clinical relevant outcomes. They might have stopping rules or crossover in order to encourage recruitment of patients, and also for ethical reasons. There might be gold standard measurement of health outcomes. Resource use is dependent on the setting. For example, resource use might be very different in the United States versus other countries, such as in Europe or in Australia. And there's inadequate follow-up from an economic evaluation point of view. For example, the clinical trial might only be run for a couple of months, and we're actually interested in the patient lifetime. So health technology assessment often involves systematically synthesizing data from both randomized controlled trials, but with additional evidence, such as real-world evidence, using an economic model. There are different types of uncertainty in health technology assessment, and the first one is methodological uncertainty. This arises from deviations from that suggested, or the method suggested in HTA guidelines. And the reason why we call it methodological uncertainty, it's because there's often a bit of debate within between payers and decision makers, or within the health economics community, about the most appropriate approach. For example, what is the most appropriate comparator or the most appropriate perspective or discount rate? There could be uncertainty in the structure of a model or between the relationships between certain parameters or over time. There's often parameter uncertainty, which is about what is the true value of a particular parameter. So all parameters generally have some form of uncertainty around them. So this is typical. We see this with 95% confidence intervals. And this might also happen not only due to differences in sample size, but also due to limited or multiple data sources or other forms of quality, such as bias in the analysis or indirect comparisons, for example. And finally, we have generalizability uncertainty, which is about how generalizable are the results to the population of interest, so to the country that I'm interested in. We can measure uncertainty in health technology in really two ways. The first one is what we call deterministic, and this includes univariate sensitivity analysis, where we vary a parameter by their upper and lower 95% confidence intervals. However, this approach is really only applicable to parameterizable uncertainty. So the uncertainty where we can put a particular parameter on it, so such as the value of a utility value or the value of a cost. We can also use scenario analysis, which is about more extremes, and this can be used to analyze methodological uncertainty or structural uncertainty. We can do subgroup analysis, which usually involves more than one parameter, and that's really about addressing generalizability uncertainty. And finally, threshold analysis is incredibly useful for looking at parameters that are highly uncertain, or alternatively, there can be some negotiation around, so for example, price. Then we have probabilistic sensitivity analysis, and generally this is very similar to deterministic analysis, but we put a probability on a particular value being true. And the problem with this approach is it really is only applicable to the types of uncertainty where we can parameterize it. So it's really good for parameter uncertainty, and it's much more difficult if we're looking at methodological or structural or generalizability uncertainty. We could present the results, generally with deterministic analysis, whether it's univariate sensitivity analysis or scenario analysis. We usually present it in terms of a tornado diagram or a table, whereas probabilistic sensitivity analysis, the results are often presented in terms of a cloud plot or a cost effectiveness analysis or a percentage that the particular evaluation is likely to be the most cost-effective evaluation. Now, the problem with probabilistic sensitivity analysis is that you can't use it for inference like you would with like a clinical trial where you've got a pre-specified hypothesis, because you haven't generally powered your health technology assessment to determine whether or not there's a significant difference. So how frequently do we encounter uncertainty in health technology assessment? Well, it's ubiquitous. It's everywhere in health technology assessment. Very few parameters are definitely certain. And the only ones I could really think about are if you had a particular kind of intervention where you knew the patient received it, such as surgery, or the cost of the offered cost of a particular intervention. Most parameters or some parameters are uncertain. And so these are like the dose received, the efficacy, the risk of adverse events. And generally we see 95% confidence intervals around these. But many, many more parameters are very uncertain. So we often don't know the quality of life of the patients really to a very specific measurement. We have a lot of uncertainty around that. The duration of efficacy, the duration of those adverse events, future health costs, and so on. Regardless, the bigger issue is risk. It's not uncertainty. There's always going to be uncertainty. The issue is risk and how we deal with it. So what is exactly risk? So according to the International Organization for Standardization, risk is expressed in terms of risk sources, potential events, their consequences, and their likelihood. So if we apply this to health technology assessment, the sources of risk are things such as uncertainty regarding the inputs and modelling, the lack of data, the selection of that data, inappropriate assumptions, and bias, and so on. And these result in events. So the events might be the source might be I didn't collect enough data, or my clinical trial was too short, and as a result, I now have to conduct extrapolation. Or I didn't collect data on a certain parameter, and now I have to use an assumption. Or the data I did collect, the clinical trial had a certain level of bias. For example, there was crossover, and as a result, my estimates of efficacy might be underestimated or overestimated. So these cause events. And each of these events is associated with a certain likelihood of them occurring. So the likelihood of over or underestimating costs or efficacy, or health outcomes, and these have consequences. So the consequences are if an intervention is cost effective, but it's not funded or it's delayed funding, then patients will be generally unable to access the intervention or the medicine because they can't afford it. And because it's cost effective, this means that they miss out on valuable health outcomes, and as a result, resources are wasted. But on the other hand, if intervention is not cost effective, but it is funded, then those resources are diverted from other healthcare programs, and so other patients are denied valuable health benefits, and so on, and resources are wasted. So there are consequences to different forms of uncertainty, or risk rather. So I know this has been covered, but I'll just cover it very quickly, and I'll move on to how we deal with risk in Australia. So just very quickly, so everyone's on the same page. Generally in Australia, hospitals provide free access to public patients in public hospitals, and that is funded by the state government. In medicines are subsidised through the Pharmaceutical Benefit Scheme, which operates a positive list of medicines that are funded. This is funded by the federal government, and decisions are made by the Pharmaceutical Benefits Advisory Committee about what is listed on that list. Medical services such as consultations with GPs or specialists, or imaging, or other diagnostic tests, they're listed on the Medicare. So these are out-of-hospital services. These are listed on the Medicare benefits schedule, which is also funded by the federal government, and the decision is made by the Medical Services Advisory Committee. So in, for example, the UK, the National Institute for Health and Care Excellence, or NICE, makes both decisions about medicines and medical services, but in Australia, we've split these across these two committees. So in terms of risk management, I'm going back to that International Standardization Organization and how they recommend how to do risk management. I'm going to apply that to health technology assessment in Australia in practice. So the first one is that how the processes of doing risk management is outlined in the guidelines. Generally, the risk identification occurs through deliberation, multi-levels of deliberation, whether it's through evaluation groups. So I'm a member of, I run a team of individuals at a university, Macquarie University, that conducts evaluations for these committees, followed by the Economic Subcommittee, the Pharmaceutical Benefits Advisory Committee, or the Medical Services Advisory Committee, and also the Department of Health. Risk analysis occurs through those sensitivity analyses, whether it's both on the incremental cost effectiveness ratio or on the financial impact. I should note here that the Pharmaceutical Benefits Advisory Committee really, and the Medical Services Advisory Committee really focus on deterministic sensitivity analysis. Even though probabilistic sensitivity analysis is listed in the guidelines, I've got my PhD student to do a search and we only found about 2 instances of it happening. So they really do focus on deterministic analysis. The next step, the risk evaluation, is largely deliberative. In other words, a discussion around within a committee room. And then there are several options. So just because you identify, there is things that you can do about a risk or reducing that risk. And that is called risk treatment. And so there are options. You can avoid the risk by not saying it's not cost effective and not listing it or not funding it. You can accept the risk and recommend it or fund it. You can reduce the risk source, the likelihood of the consequence. For example, you could restrict the population, or you could reduce the price. You could request more data or a reanalysis. You could also transfer or share the risk with another organisation or individual, but usually organisation. And in this case, like the medical device companies or the pharmaceutical companies. And this is generally through managed entry agreements. So, for example, financial caps or coverage with evidence development agreements or patient performance agreements. And finally, you should have, they have contingency plans. And so this is what happens if the event occurs. So this is things like restricting the population further or reducing the price or delisting. And finally, this whole process of risk management is communicated to the public through these things called public summary documents, which outline the different sources of the risk and how they're treated. So, as an example, this information is all publicly available, but we have ivacaftor for the treatment of cystic fibrosis, which was an incredibly expensive treatment, which was first considered in 2013. And in that situation, there are a couple of forms of uncertainty. So, for example, the trials excluded patients with an FEV1 that was less than 40%, but the restriction didn't include this restriction. The trials were generally short and showed efficacy against a surrogate outcome, but not survival. And the committee was most interested in survival. They considered the extrapolation of survival was highly unreliable. They questioned the generalisability to the Australian population, and the utility values were considered to be uncertain. Oh, sorry. So in terms of the risk analysis, they looked at the consequences. The base case incremental cost effectiveness ratio was initially estimated to be around 200,000 per quality adjusted life years. That's in Australian dollars. And the ISA was, which is actually very high because at the moment it's about, in terms of US dollars, it's about 0.65 Australian dollars is equal to $1 US. So it's very high ISA. And the ISA, they also considered the ISA to be underestimated. It's likely to be actually higher than that. They conducted the risk evaluation deliberatively over a variety of both the first consideration and also the resubmission and also an interim meeting as well. And then they came up with a final decision, but also it included a variety of different risk treatments. So, for example, they reduced the risk by both restricting the population so that they patients are required to do sweat chloride monitoring. They reduced the price, and it was specified that the incremental cost effectiveness ratio had to be between $60,000 and $80,000 per quality gained. They transferred the risk using a financial cap, specifying that the sponsor had to pay the first 6 months of treatment until clinical response, and requiring additional data collection using a registry with a very large list of additional variables to be collected. And they also required that there was a guaranteed price reduction after 12 years when the medicine became off patent. Finally, they were able to communicate all this information to not only the pharmaceutical companies, although I'm sure there were meetings behind the scenes, but also more importantly to the public and patient advocacy groups through the public summary documents. And all this information is available on the internet for Australia. So just some final thoughts. The presence of uncertainty there is research that shows the presence of uncertainty in health technology assessment does significantly reduce the likelihood of a positive recommendation in Australia and internationally. However, uncertainty is present or ubiquitous in all health technology assessments, and ultimately it cannot be avoided. And there are decisions to fund or not fund an intervention. Decisions to fund or not fund an intervention has subsequent consequences. So, however, it needs to be noticed that we're not dealing with uncertainty, we're dealing with risk. And there are ways to consider that risk in a much more holistic and systematic way using a risk management approach, which the Pharmaceutical Benefits Advisory Committee, does do, and I'm sure other payers also do. It's just they're not necessarily aware that they're doing it. And that is it from me. Thank you very much.
Thank you. Okay, we are after all very interesting presentation. Thank you very much for sharing your knowledge with us. Right now we start the question session. I didn't receive any questions from chat, that means from the internet. Maybe there are any questions from here, from the room. Yeah?
I have a question for the first lecturer, for Mr. Justin Clark.
Of systematic review is actually very interesting for me, as I perform systematic reviews and I know how much work they require and how time-consuming they are. And I have two small questions. First, is this tool, this systematic review accelerator, is it commercially available, for external parties? Because I didn't catch that. And the second one, probably more interesting. Does it include any features that use artificial intelligence? And if not, do you think that it will change in the near future? Because it seems like AI has a great potential also to affect systematic review process. What is your opinion on that?
Thank you. They're great questions and very pertinent, because we just had a discussion today about those two exact things. At the moment, the Systematic Review Accelerator is free. It does not matter if you're a commercial company or if you're a researcher, if you're a student, anyone in the world, if you have an internet connection, can use a Systematic Review Accelerator right now. We are planning, though, to improve the workflow functionality of everything and kind of commercialize that aspect, so it will guide you through the systematic review process, and it'll be a lot easier for novice users and new people to do systematic reviews using our tools. But at the moment, every tool is free, and every tool will stay free even when we move to a commercialized platform. But we're just building a workflow integration layer which we may commercialize that aspect. So that guides you through the whole review process, but you can still use every tool individually for free. So everything's currently free right now, and we plan to keep every tool free into the future. AI is, of course, a great question, and that's a very hot topic on everyone's lips and in everyone's minds. Where does AI fit into systematic review or HTA or evidence synthesis production. At the moment, there's been some early preliminary research. I have read some and done a bit myself and working with a few others. At the moment, AI is not very good at doing systematic reviews. So although it can do them, it gets the wrong answers a lot of the time. But I don't doubt that this will improve over time, and I think AI will play a large role in systematic reviews or evidence synthesis into the future, especially as it starts to get used more and the models get trained up. And as for whether we will use it, we met with some computer scientists from the University of Queensland today, and what we are going to do is they've done some AI research using AI and large language models to help design search strategies and to help screen results. We are planning on working and partnering with them to embed their tools or to embed their AI research into the Systematic Review Accelerator and to use AI to help people build searches and help people screen studies into the future. That was our first meeting today, but they've got some very promising results. So we do hope maybe in about 6 months' time we will have AI integrated into our tool suite. But I need to point out that using large language models is very expensive. So even if we do, when we integrate AI into our tools, that won't be something we can offer to people for free. I think, for instance, to screen for one review, so just one systematic review, to use large language models to screen costs about $200, 200 Australian dollars to screen for a review. So we will be offering that service, but I doubt we can offer that part for free. So people will be able to opt in, I guess. That's our plan anyway. People will be able to opt in, use AI, but there will be a cost, though, to use AI. Maybe in 2 years' time, large language models will become very cheap and easy to use and much more available, in which case, of course, we will bring any associated costs down. But we couldn't afford to pay for every person to use AI to do the reviews using our tools. So that would be kind of an opt-in. Do you want to spend $300 to use AI to help do your review? That would be kind of the model we'll be looking at into the future, until the costs of AI reduce. Then we would reduce our associated costs, of course. So hopefully that answers your question.
Yes, thank you.
Okay, thank you. Any other questions from the audience? If not, I have questions to Magdalena. And in case of pharmaceuticals, they have quite long lifetime. That means the cycle of pharmaceuticals is quite long. In the case of medical devices, it's accelerated. They can change. The producer are releasing the new versions, and sometimes you are assessing in HTA completely different device based on different evidence. But in the case of digital solutions, digital applications, it is much more faster because this application can change almost every day, or it can be updated very frequently. And how to deal with this problem, with how to assess based on the evidence is completely not fitted to this solution that is currently available on the market.
Yeah, so you're very correct. One of the unique challenges posed by digital health technology is their life cycle and their propensity to be adjusted quite quickly without let's say, the regulator or the HTA body knowing. This is particularly evident with apps, as it's distributed by a third party, like an app store, and not through government regulation as medical devices, traditional medical devices, medicines are. So in the module that I created, I tried to adjust for this by making a new domain that was post-market monitoring, and indicating when a HTA would be triggered. So if let's say an app, if the update is purely corrective, like for a glitch or an error, a HTA wouldn't be needed. However, if, let's say, post-market monitoring data by the regulator or even the Department of Health in the respective country is indicating that something is very wrong, there's a lot of people reporting adverse events, or there's a, the app isn't having correct uptake because the data input is burdensome or something, that would trigger a new HTA. And most importantly, a new HTA would be triggered if the post-market monitoring data by the relevant government body is showing the technology or the app is significantly less effective or safe than was indicated in the HTA, or if they're adding or removing functions within the app.
Okay, thank you. In Poland, where we live, we have problems even with assessment by HTA bodies of pharmaceuticals, because the process takes about, right now, the mean average time of assessment by HTA starting from the reimbursement application to final reimbursement decision is about 2 years. That means quite long time. It's for the pharmaceuticals, where everything is defined by the law, the timelines of this process. In the case of medical devices, the timelines are not defined in the law. And it takes even a few years to assess and to give the final decision regarding medical device. And right now, we don't have any experience in assessing digital technologies, but I think if this process will be quite long as for the medical devices, we'll be assessing dinosaurs, not currently available medical solutions, and it will be quite inefficient and wasting of resources of decision assessing bodies here in Poland.
I guess with we try to adjust for that with saying that we can use different types of evidence in the framework to inform different sections of the HTA to see if it can get done faster. I guess we need to do more in focusing with effectiveness and safety, because that's traditionally comparative data. So I think that's the real issue. If there's a way to use more innovative forms of evidence within the framework, I think that it could address, or I hope it could address, the challenge you've described there about how long it takes to do and how fast digital technologies change.
Okay, thank you. Mark, I have a question to you. The first one is, where is my question? How informative are claims data from the payer, and if the claims data can be translated to real-world data, and later this real-world data can be translated to real-world evidence, how efficient it is, and is it possible?
So we actually have some experience with that, even within the stroke project. So the key problem actually from claims data is data ownership. They don't typically, from analysis and out, what we've run into is they haven't allowed us to share or use the data. So within Serbia, for example, they have, and I was actually involved in a World Bank project for developing their DRG system, for example. So there's a lot of data within the DRG systems generally for measuring resource consumption and resource use that's very, very detailed. But as of this moment, it's not particularly accessible. I would hope from the discussions yesterday and the transparency and the accessibility, and one of the big problems with that specifically is actually the anonymization. So it's very difficult to anonymize claims data. But actually from a payer and from a decision maker and an internal to a healthcare system, I think there's an absolute push towards that, and I think it's something that's already in process kind of generally within the region in terms of what's happening with, particularly with the adoption of the DRG, so the diagnostic resource use consumption. Croatia, I'm not sure where that is in Poland, but Croatia has quite a lot of DRG kind of publications in terms of what that looks like from the diseases. We have, that's phenomenally useful from us for understanding the burden of diseases and the prevalence and how much is actually being used from it. It's a lot of the problems and challenges that come from that come from things like coding issues. So I don't know how familiar people are with ICD-10 codes, but actually for a lot of health economic analysis, ICD-10 codes are particularly problematic. So you have, for example, first and subsequent stroke ICD-10 codes. You only have one ICD-10 code particularly for myocardial infarction. Oncology ICD-10 codes are like basically one code. They have no staging information or any detail like that. But they do have struck by a duck and sucked into a jet engine for the second time. So this is very much a kind of coding, I think, as this gets used more, and it really is something that's been particularly, I think this is the virtual trials particularly, and the digitization and the phone and the mobile apps, because what we're seeing gradually happen there is a lot of that transfer into these phone applications, and that should really drive, I think, some of the changes that are needed in that data, in that coding, in the what exists. And from a governmental institution perspective, they just need the will to start developing it.
In Poland, we have a common problem that we don't have access to this data. We are asking several times, and our payer refuse to give this data, maybe for some small projects that are available. And we have lots of problems with this coding, that very often these codes are completely misleading, and very often the clinicians are writing the code that is connected to payment, and if the payment is better, sometimes the quite close code is attached to the patients to give the better reimbursement.
Yeah, so and just to add to this is one of the things we're looking at with National Health Model, because the idea behind National Health Model is we give them what we think it should be. So we say, this is what we think your data should look like. So the challenge of them providing the data, they don't need to provide us any data at all. They just need to provide us information on where it's different or where this goes. This is particularly useful for the for this anonymization kind of aspect and the data ownership, because what we're doing with the share with the this is providing that this is what we think it should look like. We don't need actual access to the data to do the validation process. And this second part of where this goes with actually working locally and this provision of data, I just want to say the UK has what they call the GPRD database. So that's actually, if I was suggesting anything, to look at the processes that they've put in place for that GPRD database. So that is used a lot in research that comes out from the UK associated with this, which is data collected from every GP practice in the UK. That's made available for research. And we heard a little bit yesterday, I think, on terms of what's going on with these kind of common data access platforms. So I think a lot of it is they don't have the processes in place to make the data available for research. And that's I think something that absolutely has to change, and I think the healthcare system, when that's in place, healthcare systems will end up better for it.
Okay. If you can compare the desire of decision makers in Central and Eastern Europe to such policy models as yours regarding the disease management, and how these models are, I think, desired by the decision makers, and the difference between Central Eastern Europe and Western Europe or Western world.
So I think one of the differences, the key difference between Central and Eastern Europe and a lot of the Western countries is Central and Eastern Europe are very focused on real problems. So there are a lot of big problems, very constrained budgets. When you look at it from a Western perspective, there's money to throw at any old problem if you could make a reasonable story for it. So there's a lot more wastage in the type of things that are done, but at the same time that's ended up with a lot more kind of innovation and development. Sorry, just repeat the kind of second part in terms of
how this, yeah, I think if
well, I say it's just in terms of where this comes from, in terms of the desire for the data, I think it's, so what I wanted to put on this particularly, and we found this particularly with the stroke project. So I was one of the things I'm happiest with the stroke project is we completely got very closely involved in redefining their clinical, their clinical guidelines. So within the neurology department, the engagement from clinicians, when clinicians were given the tools to provide the evidence they needed to make the case, was breathtaking. From a complete change of apathy and disbelief that anything can change and there is no possibility to, I know this now. I have proof that what I thought was true is true, and that allows them to run with it. And there are quite a lot of similarity. The challenges for Central and Eastern Europe and the UK are very, very similar, but the contexts are very, very different, and some of where the challenges are most acute are quite different. So you see one of the example I give in Serbia, which is never talked about, which is one of the best improvements in their healthcare system since I've been there, is they bought new ambulances. So suddenly they actually are in a position to, when people have acute problems, to get them to the health services that exist. And one of the biggest problems prior to that was people would not make it to the hospital in the first place. So this is really what I talk about. What I've looked to is this idea of real-world context. It's what does this mean locally? What are the actual local issues? And I think this development of data and very localized, specific data is very important for understanding what that looks like. From a publication perspective, that we say this all the time, how transferable is this data? Well, that's really what we're talking about is what are the contextual differences from a local system, from where it was collected, and understand, okay, I think the last presentation on risk is a really good example of that, to take it from a risk approach. What's the risk of this not being transferable?
Okay. The questions to Bonnie. Right now, we see the trends in authorization of new drugs, especially this one with multiple indications, that authorization bodies are agreed to lower the evidence. For example, agreed to next another indications, just authorize them based on the single-arm trials or short-term clinical trials. And how do you see the future and how it will impact the HTA decisions regarding these pharmaceuticals in Australia?
I think that's a really good point. I think the further we move towards biomarkers in particular, or pharmaceuticals that are associated with biomarkers, we're going to have more and more limited evidence in order to make those decisions. But that's when the risk treatment aspect kind of kicks in and becomes more important, because yes, the uncertainty is going to increase over time as we have evidence which isn't as the large clinical trials as we've seen in the past. But at the same time, it means that we're going to have to make decisions based on those limited evidence, because we're still going to make a decision. We still have to make a decision whether or not we fund or don't fund the drug, and if the medicine ends up being cost effective and very highly effective, patients are going to miss out. So we still need to make that decision, but there is opportunity to kind of mitigate or manage that risk using a variety of different risk treatment tools, such as agreements to reduce the price, agreements to share some of the risk using managed entry schemes or agreements, or to provide evidence, provide funding and coverage while additional evidence is collected, for example, using real-world evidence, and then later on going back and going, was that assumption about that particular parameter accurate or not, or do I need to slightly change my assumption? And in addition to that, not just making that decision, okay, I'm no longer going to fund the drug, like delisting, because delisting is always politically difficult in addition to ethically difficult and practically difficult. But having other strategies such as, okay, we'll agree if you don't reach a certain parameter value, if we agree in advance that you're going to collect this data and this is how your data collection is going to look like, this is the registry and this is the variables and this is how many patients you're going to include in the registry and this is how we're going to analyze the data. If you don't achieve a particular parameter value, then your price will decrease by a certain amount, or you will rebate us a certain amount for those losses in the meantime. Or it could be the other way around. It could be that the price goes up in the meantime as a result of better than expected results. And I've certainly seen that as well. I've seen the price go up, but I've certainly seen better than expected results in clinical practice compared to a clinical trial.
In Poland, we have the same requirements for each indication, but for example, in Europe, in Belgium or in Netherlands, they have developed some other solutions that are assessing this first indication. This is the case of PD-L1 inhibitors. But for the next indication, they just required budget impact, and they are negotiating just the price and the size of the populations in the process of negotiations. That means some new solutions are also here invented and implemented into system. Mark, do you have any questions?
Always. It's whether I can ask them or not. I think one of the things I'm not sure particularly who I would address this to, but particularly when we were just talking about this idea of price and reimbursement, I think there's guidelines play a very important part in this as well. So from a clinical recommendation, what is the recommendation for clinicians to do? This isn't just a should we reimburse it, what population should we reimburse it? There's that at the top level from the benefits package perspective, but really one of the other things that can really drive what populations actually end up using different products are what the clinicians themselves are recommending and how that fits in with their actual guidelines. So it's, and we've absolutely seen that, where the example I gave where insulin degludec had its was from reimbursed went from 11,000 euros to 4 million euros. There's examples on there where it didn't change at all when it was added to the list, because it was already clinical best practice, it's already a relatively cheap treatment, and the only the benefits there are almost hidden, because the benefits from being on the list are the people who are least off no longer have to pay for it. But it's still, they were paying for those medications anyway. And I think that, from what I see from the UK and NICE do, they have a very, very close integration between their NICE guidelines and what they do from their technology assessments. And I think that's also a very important aspect to bring into this discussion and to bring into what's been done from the evidence. And I think my question would, that question would be, where are other countries with that? Serbia, we started. So this what we've just done with this stroke, I think, is really kind of laid the groundwork. We've had quite a lot of follow-up from other clinicians who wanted to be involved in that project. But I don't know at all kind of where anybody else is up with that and where that situation is.
In Poland, there are some areas that created their own guidelines. Sometimes the medical societies are applying international guidelines to be up to date with the treatment, but the treatment reimbursement is defined by the therapeutic programs. That means some reimbursement solutions in Poland, and the reimbursement list is completely two different words. In many diseases, reimbursement is completely not connected with what happens in the clinical guideline, and this gap is in some medical areas it's very small, but in many it's completely different. It's also Poland and Central and Eastern Europe is not in the top priority of pharmaceutical industry. We are not, the companies are not always applying just after authorization. They are waiting for the decision in other countries, in Germany, in UK, or in the big markets, and the Poland and other parts of this world are in some queue in the pipeline of reimbursement application, and it's delayed the access of the patients to the treatment, and the gap is growing in comparison to what is recommended right now in the clinical guidelines.
Yeah, and I think that's one of the other places we've seen issues is, for example, when second-line treatments are reimbursed, but the first-line clinical guideline, the first-line treatment that's recommended in the guidelines isn't. So you end up with not just delayed treatment to the second line, but patients just not even clinically eligible for it, because the recommendations are you're supposed to have had this particular treatment first before you move on, and it's like, okay, we've put we had this joke within Serbia where they were like, yes, you can get reimbursement when it's no budget impact. Well, what it actually turned out with no budget impact meant no patients get it. Was kind of that's something that's changed. That's something that's changed recently. But I think within this relationship between guidelines and HTA and reimbursement is probably something that we are currently underestimating how important that is.
Okay, thank you, Mark. I would, yeah, Monica. Just a moment.
Thank you. We are talking about reimbursement, money, ICER, and where is value in this? Where are the patient-reported outcomes? It's obviously not in medical registries. How we can address this perspective? And maybe can I ask Bonnie to answer this, and then Mark? Thank you.
Sure. So with regards to patient, the patient perspective, in Australia it comes into a variety of different ways. So the first one is obviously their input into both the submission process, where they are able to provide input into the submission. If it is developed by the pharmaceutical company, they get consulted. There's an opportunity to provide information during the consultation process, especially with regards to medical services. there is often an opportunity for them to comment on a draft decision. There is also within the Pharmaceutical Benefits Advisory Committee, there are two chairs. There's the current chair, which is Professor Andrew Wilson, but then the co-chair is Jo Watson, who's actually a patient advocate. So she liaises quite well with the different patient groups that might be of interest for the medicine that is being considered, and is also able to put forward their opinion on the particular medicine during those committee meetings. So that is how we incorporate the patient perspective within the Australian system. In addition to, if the pharmaceutical company decides to provide evidence, within their submission. The other thing I'd like to say is just picking up the point regarding guidelines. I think we're in a very similar situation as Poland, where we don't have a situation like NICE where the guidelines are developed with the consideration of HTA explicitly affecting those guidelines. Rather, those medical groups are coming up with those guidelines either themselves or alternatively looking at the international guidelines and adopting them. However, that said, both our Medical Services Advisory Committee and the Pharmaceutical Benefits Advisory Committee look at those guidelines in detail as part of the submission process and make sure that the medicine considered understands where they fit within that treatment algorithm. And then the restrictions really reflect, so there's restrictions for each of those medicines or medical services, and they largely reflect both those guidelines and where that particular medicine is cost effective. So it would restrict what treatments were received beforehand, for example, in addition to the patient characteristics. However, we also we have a 17-week evaluation period, which is much shorter than your 2 years. And so it is a very efficient process, but it's a much shorter process. And so we are able to consider medicines actually very close to launch. And usually we're actually evaluating medicines at the same time as they're being considered for regulatory approval.
I think that answers most of it. I think I'd come at this from a slightly different perspective. So if you consider something like rare diseases, which I think patient access regionally, internationally, has actually been quite reasonable in terms of paying. Not perfect in every way, but a lot of money has been spent on very small numbers of rare disease patients. And a lot of this comes down to, so the common name for it's patient voice. And it's this idea, so we have this whole, from a health technology assessment, this idea of QALY, and we know things are missing from that QALY, so add into that a patient voice. And I think things like mobile applications and collecting kind of more information on a patient perspective is going to help with that and change that. I hope to see that will be there'll be part of that incorporated into the decisions at the moment. As far as I know, that nowhere's any people are just at the moment just struggling to get kind of basic good medications reimbursed and listed. You saw insulin degludec for Serbia 2018, that was on the list. I think that's nearly at the end of its patent period. So it's this idea of patient voice and capturing these outcomes is a very, very big part of it. It tends to one of the biggest parts of it is also the uncertainty. So there is so much uncertainty on it, and this whole idea of EQ5D, it's the best we've got, it's also terrible. So, but it's the best we've got for measuring that. So we have to make that decision given the uncertainty, and there are a lot of risks involved in that. But bringing in patient voice, bringing in these other aspects to what the consequences for patients are, I think is really important. One of the things I was left with from these last couple of days is, keep hearing about this mental health crisis. Well, if our patient tools are not measuring mental health, why are we surprised we have a mental health crisis when it's not something that's realistically being considered in any of this decision making? So, you know, we have a long way to go. You know, it's great we have lovely new toys that are producing lovely new data and the rest of it, but at the same time, we all have a long way to go in terms of developing these. And I think things like the systematic review tools that we were talking about, I think are going to go a long way to do from that, simply because historically systematic reviews have been so enormously time-consuming and expensive. So as that becomes something that's more accessible and more achievable within resource-constrained environments, I think we'll start to see that go in the right direction.
Okay, thank you for these final comments. We came to the end of our session. I would like to thank you all the participants, all the guests from faraway Australia, from our perspective, and thank you, Mark. And thank you for all your engagement and sharing your knowledge with us. This is educational symposium to teach us how to improve in our everyday decision and our work, and thank you for that. And right now we have a 10-minute break, and thank you and goodbye.